Mezcal or tequila?
The mezcal is better, yes, of course. But not Intrathecal.
You were going to move that in some way.
No? Yeah. In my life, when in my clinical activities, and when I have an opportunity to involve it in this passionate topic with the clinician activities, and in the deck to the 85 years, more or less, when I worked in the General Hospital in Mexico City.
Yeah.
The General Hospital is in this time is the more big hospital maybe in Latin America, because this big hospital included small hospitals in each specialty, surgical activities or neurosurgical, intensive care, anesthesia, orthopedics, all like the more big hospital, a lot of beds in the hospital. And then in this particular time, not exists in my country opioid medication.
Yeah, and what year are we talking about here? What year are we saying? Is this?
It's 82, 81.
81. Okay.
Yes, but 81. But not exists in the 70 deck. In the not exists, only exists ampoules of the meperidine.
Oh yeah.
And,
wow.
and pentazocine.
And did you see a lot of patients in pain at that time?
Yes, a lot of
suffering.
patients.
Pain didn't
but
exist before the 70s.
This is the very important question, because in this particular time, the more high incidence of cancer patient is through the cervical cancer, uterus cancer, not breast cancer.
Oh, that's very different.
Different. And now it's different, but in this time in Mexico, and I hope in Latin American countries, is same. I remember when I moved to the National Cancer Institute, like a chief of anesthesia and intensive care department, not exists service of pain medicine, only in anesthesia and intensive care.
Yeah.
And not exist. I moved to the General Hospital, to the cancer hospital in 83, more or less.
Now today, when we think of cervical cancer, we think we got to do superior hypogastric block.
Yes.
How did you come up with that, or what led you to do those kind of things in 1981 and 1982?
When I moved to the National Cancer Institute, I proposed of my director, general director, to founded the pain clinic, and then he said, "What is this?"
What is
That happens today too. No different.
And I say that for the special in training people or study the patient within another physician involved in the problem in cancer, in cancer suffer.
Yeah.
In cancer suffer. Not exist suffer here.
Yeah.
He say, this is not important for this pathology, no? This pathology is possible to resolve it through the chemotherapy, surgical, and radiotherapy options.
So they assumed that those treatments would treat the pain, but did you find that they were they were suffering before then, just even trying to get the treatments? So they're when they're getting it, they're getting chemo, they're getting radiation, they're still suffering.
Yes, but what is the when I questioned it to my director in this time, I think this is possible to help more to the patient through the different options for the treatment, the pain. And he said, this is not important here because the neurosurgical resolve it through the cordotomies, the pain in cancer patient.
So before the hypogastric block, they were doing cordotomy open probably because they're cutting people open and doing that to the spinal cord. And instead of intrathecal neurolysis, they're cutting it.
The intrathecal neurolysis is, in my opinion, in my personal opinion, I present this experience, is a very old friend. Very old friend. Intrathecal hypobaric or hyperbaric option. In the best good results that in my personal experience is in thoracic area. But in this time, in thoracic, because if you remember this classical, very old technique designed for the other people in other time, historical time of the medicine, the distance through the root, anterior root, that the posterior root in intrathecal area in the spinal cord is more big or is big in thoracic area. In cervical is very close.
That's
and
true.
In lumbar not exists because the conus. And then if you pretend to perform this option for the treatment, there's some indication to denervation of the is more successful in the thoracic area because it's more exactly to intervention in the posterior root, not in anterior root. Especially if you apply the option to the hypobaric preganglionic denervation, no?
Just to put in perspective, how quickly can you do a thoracic neurolysis compared to someone like us that have these days in this country, we're putting in spinal cord or dos root ganglion stimulators, or we're putting peripheral nerve stimulators.
No, listen, another history. Not, for example, I denerved 12, 8, 7, 5 metameras in each in one side, and not involving nothing the motor function.
Oh wow! You didn't get any motor function with intrathecal neurolysis.
It's very cheaper. You use
alcohol or phenol or
alcohol for hypobaric.
Do you use mezcal or tequila?
The mezcal is better, yes, of course, but not intrathecal.
You're going to look at it in some way.
No? In Mexico, there exists the words they say in the Spanish is para todo mal, for all no good, mezcal. And para todo bien, everything is okay, también. It's good.
Very easy.
I gotta go to Mexico.
Very easy.
Sounds like a happier place.
Yes, but the new technologies, the spinal cord stimulation and ganglions and whatever, is possible in some to use in applied and in some countries, not in all the countries. Of
course.
This is I think it's very important to offer to patient that patient needed according to the to the facilities, no?
Yeah.
The economical facilities.
Definitely economic limitations to some of these things. And also indications are changing in cancer where some people are living much longer.
Yeah.
So neurolysis may, maybe for 5 years, cordotomy or neurolysis, you don't know what happens in 5 years, and they'll be different. So.
Yeah, I mean, that is pretty cool where you come into a place and you say, we have no options, that we're doing things for patients and we're relying on chemo and radiation to treat them. And you say, hey, I can do something very quickly and actually very cheaply, things that you already have, and it offers a significant benefit. And then the other side of the coin, the things that they're doing is you're cutting their nerves entirely with a cordotomy and they're losing function. That's the other option. So you're revolutionizing the field in that very early phase. I mean, for me watching this, obviously I've learned from Amit for a long time, but I am guilty. I don't know where these things come from. So I mean, I hear about you and I'm like, oh, this is a guy that's on all the papers, all the people I'm learning from. And now I hear kind of like, oh, this is what you're dealing with at your time period. Yes. I'm in a time period where I'm learning about pumps and stims. And
yes, another, but listen.
But we share Mezcal together.
But I think that including this particular time, if you have opportunity to implant a bomb, intrathecal bomb, for example, if you previously denervation, reduce the total pain, reduce the compromise of this technology.
Yeah.
Especially in some particular situation. It's not possible to generalize this opinion. But if you implanted the stimulators and maybe you have opportunity to reduce the levels of the metameras that you need to treat through the implanted the stimulator in the spinal cord, maybe you have best results with these new technologies.
Yeah.
And in cancer is another words, but in the chronic pain with that, or in survivals.
Yeah.
Yes. Or in survival. Yeah.
It's funny you say that. I mean, maybe I should just talk to you sooner. But I've kind of feel like that same way where before I go to these like highly kind of surgical and implanted devices, saying that if I can minimize the pain they have by a celiac plexus neurolysis for pancreatic cancer, can I decrease the burden that they need there? And then if they're still having lots of pain, they have mets elsewhere, then placing the pump for that residual pain, but not needing as much of the medications, not needing as much of that. So I do like that approach a lot. I mean, that's obviously years of experience just going through that.
About that, the celiac plexus blockade, that
you hate it.
I have many years I don't make it. Many years don't make it celiac plexus block.
Yeah.
Because the celiac plexus, the anatomical distribution of the celiac is very exposed to the modification to the anatomic distribution of the celiac plexus.
Yeah.
And it's very easy to modify the surrounding to the anatomy of the distribution, especially in the retroperitoneal area, obviously.
Yes.
Through the tumor invasion, inflammation, fibrosis for surgical, and this is the reason that I try to find another option with less dangerous or side effects than the classical intervention in the splanchnic nerves.
Yeah.
Because the classical intervention in the splanchnic nerves have especially in with the fellows is in training, is punching the lung or have another different.
Never seen that. Never seen
yes,
that.
never. Yeah. I know, but the with the experience that they making the approach to the different disc for other pathologies in the lumbar area specific or cervical area, I think why not use the way through the disc for go up to the splanchnic nerves?
Yeah.
And this is the technique that reported.
Definitely knowing the anatomy very well. The neuroanatomy has been very helpful to make these blocks very specialized and become more effective.
Yes.
That's something that I know you learned very early on, but how do we teach the young generation the same things in 1 minute because they're watching a TikTok video?
Yes, it's true. It's true. But let me, the history to the 18 to 19 changed by country.
Yeah.
Because I worked for adopting the cancer pain program through the WHO.
Yeah.
And I coming to New York, specific to your hospital in the 19th when the chief is
I saw this picture.
Maybe
I saw this
Foley?
picture.
Kathy Foley. I have a picture with Kathy Foley, and she called me for adopted in my country the cancer pain program. In this time, the Kathy Foley is a chairman, a head.
Yes, preeminent.
Yes. I remember my friend physician from India, the Subhash.
Yes.
Subhash Jain is
yeah.
working with the procedures in the pain clinic, and Kathy Foley and Vittorio Bettafrida from Italy is a big people in the WHO programs in the world. And these personalities helped me for adopting the program. And now in Mexico, they exist from this time, the 1993, 96, signed the compromise for exist this medication.
Yeah. A very important moment in history
I
for
think
pain medicine for sure.
Yes, especially in cancer. Yeah.
Yes.
Yeah.
And another pathologies, not only cancer.
Yeah, it really percolated through.
Yes, morphine is morphine.
Not mezcal, but close.
Yes, but close. Tequila is tequila.
What do you see as like, now that you've kind of been through the gamut of things where it started, what do you see like now? Where is the future of a lot of these things? And I like where you started with the simple, elegant solutions that may not be these high, like long surgeries and things. Are there things that you see in the future with just things like neurolysis? Or, I mean, obviously, we didn't even touch on cementoplasty, but various other things. Are there things that you see in the future that may kind of revolutionize the way that cancer is treated now?
The future.
Or maybe there is nothing. Maybe we discovered everything.
Listen, when this question is frequent to people ask me, what is the future? I think in best future.
Yeah.
I hope that all the people have a best future in all the situation. But in pain medicine, the neurolysis. Let me try to explain. I think it's like a salami syndrome. You need it cut here and now here and now here, and it's interruption, no? Salami syndrome, no? And I hope that in the future, maybe through the personalizing medicine, personalizing, individualizing, founded in the increase the research in the genomic.
Yeah.
Is possible to modulate some genetic situation and not use only the actual option of the salami. Salami syndrome is applied through the another option to spinal cord stimulation. Mm-hmm. It's a salami syndrome with other options, no? Yes. I think so. Maybe I think the people expand is expanded. Is expanded. And maybe some people not accept this, but it's interruption in the nociception in different levels with different options.
Without cutting.
Yeah, according to you.
Yeah, I mean, I feel like we got a lot. We got a great glimpse into your life and where things were and how far things have come. I mean, I think this has been great to learn.
Wonderful to have you as one of the legends of pain masters and gurus and share your wisdom with us. And I will never see salami the same ever again.
Thank you so much.
Always learn something.
It's better somebody to eat.
We need to have a salami here and a mezcal.
No, but neurolysis, I think, is very important tool in this moment and the many years coming up because interruption with good hands, with entraining people. For instance, I think this is very important to include in all the knowledge expression, the cadaver course.
We agree. I agree. I think one of the things that has fallen off in cancer pain medicine in this country is really, I mean, many of us don't do these procedures anymore, but just the education of those procedures are not being performed, especially for intrathecal neurolysis. It's something that we need to learn as cancer pain physicians to really be able to offer that when necessary. And I think the training for that in this country is lacking.
No. It's a lot, yes, but specifically in the sympathetic system, if you compare the balance, the risk of the denervation of the somatic system versus sympathetic system. In my opinion, exists less side effects in the sympathetic system.
Yeah, definitely not wrong.
But and then why not apply it more? This alternative when you have patients with mixed participation of the somatic and sympathetic and non-nociceptive pain, neuropathic pain, but not exists panaceas. But if you reduce the total pain, small reduce, you have opportunity with another alternatives more successful. Reduce the medication, reduce the side effects, and it's by my experience, though, in the sympathetic area.
Definitely a great option for our patients.
Yeah. Thank you so much for stopping by and talking with us.
Welcome.
Thank you.
Thank you.